All right, let's get started. Good morning, good afternoon, good evening, everyone, from wherever you are logging in. I am Adrian Tadella of Core Group. I am the Knowledge Management Officer for the TOPS program as well. This morning, we will hear from Medical Teams International as they present their work on developing an instructional video and an accompanying learning tool and the partnership defined quality process. The video and the learning tool, which you can actually find the links um, at the bottom of your screen. You can download the learning tool from here as well. Both the tool and the video are products of the Top Small Grants program. Um, our presenters for today are Beth Outerson, who is the Capacity Building Advisor at MTI. She builds staff competency in community-based primary health care through training, project support, and development of online resources. Previously, she worked as Adolescent Reproductive Health Advisor at Save the Children, where Beth applied the PDQ in 6 countries. Beth began her career in migrant health and was a Peace Corps volunteer in the DRC. She has an MA and an MPH from Tulane University. Next, we have Andrew Hoskins. Andrew has served for 3 years as country director for MTI Liberia. He started just when the Ebola crisis hit that country. MTI soon became a leader in infection prevention and control, and Andrew has spent the last 10 years working in Africa, in Mali, Ethiopia, and Liberia. He began his career as a Peace Corps volunteer in Niger. Andrew is passionate about world poverty economics, faith, and social justice issues. He has a BA from Mid-America Nazarene University and an MA in International Development from the University of South Carolina. Before I turn it over to Beth to start the presentation and discussion, I would just like to note that this webinar is being recorded and that the recording and any other presentation materials will be available on the FSN network right after this event. And for any questions and comments you might have throughout the presentation and discussion, please type them in on the chat box. We will not be providing participant microphone rights for this webinar. We will take your questions and get through them during the Q&A. All right, so now I will turn it over to Beth to start us off. Beth?
Wonderful. Thank you, Adrian. Can everyone hear me? You can just type in yes, or if you prefer, you can click on the top where you can raise your hand using the little toggle thing. Okay, great. So I'm going to go to the next slide. I'm assuming you guys all had a chance to watch the video. This presentation is going to talk more about PDQ and have some content and questions around the video. Great, good. I see people typing in. Okay, so the agenda for this presentation today is first we're going to talk about what is PDQ. We're going to have a description of the PDQ video project. We're going to have some discussion, learning tool questions, next steps, and then questions for you guys. So let me see here. And then I'll be doing most of the talking. We'll have Andrew also give his perspective on PDQ in Liberia. So I'm moving on to the next slide. So what is partnership defined quality? A lot of this is going to be review for you guys since you've already seen the video. PDQ has 4 phases. It's a methodology that improves quality and accessibility of services by engaging community members in defining, implementing, and monitoring the quality of service delivery. That's actually one unique thing about PDQ versus traditional approaches that do not include community groups in the decision making at all. PDQ empowers providers together with community members to develop solutions together. It's mostly been used in the health sector, but there have been applications in education, HIV/AIDS, and other sectors. It was developed by Save the Children in the early 2000s and has been implemented in more than 15 countries. So as you can see in the diagram, the first phase is building support, where the implementing NGO meets with stakeholders to gain consensus about the problem and also gain their support for using PDQ. The second phase, exploring quality, involves conducting focus group discussions with vulnerable community groups as well as the health center staff. Third phase, bridging the gap, is a day-long meeting during which the agreed upon problems are identified and members of a quality improvement team are selected. Am I too quiet? Can you hear me better now? Is that okay?
That's much better, Beth.
How is
Thanks.
that? Okay, sorry about that. The third phase, bridging the gap, is a day-long meeting during which the agreed upon problems are identified and members of a quality improvement team are selected. In the fourth phase, the quality improvement team works together to make an action plan and starts addressing issues identified in the bridging the gap session. As you can see here, there are several outcomes that we commonly see from the PDQ process, including improved sense of ownership of the health facility, improved provider satisfaction, and shared rights and responsibilities for better health outcomes. Can everybody hear me okay now? Sorry about that. Okay, great. So I'm going to move on to the next slide. Great. Okay, so MTI received a top small grant to produce this video. We wanted to capture the PDQ process to show it how it's being implemented in Liberia. And if you look at the picture there, you see one of the quality improvement team meetings in a community, and you see the two video guys there doing their work. The purpose of the video project was to increase awareness and use of PDQ. PDQ has been around for many years, but its use has not been widespread. Developing a video is a great way to help facilitate the training we're doing, but also sort of reintroduce the methodology to others who may be seeking community-based approaches to improving health and development indicators. We only had about 3 months to implement the project, so a lot of detailed planning and coordination was needed between headquarters and in-country staff and the video team to plan the storyboarding, the script, notify the communities, and shoot the footage in 1 week in 4 communities in order to get adequate footage of all the different phases. In cases where we couldn't explain a concept with a video, then we described it with a narrative or with interview excerpts. So what is the PDQ video learning tool? The learning tool accompanies the video and helps facilitate learning after sharing the video. It has 4 sections: frequently asked questions, discussion questions, PDQ resources, and the actual narrative script that was used in the video. In this webinar, we're going to focus on the 2 areas that are in red, which are the frequently asked questions and the discussion questions. The frequently asked questions discussion section answers some of the questions that were not included in the video that people may have. Most of them relate to the logistics and feasibility of PDQ. So I'm just going to read 2 of these questions because there's a lot on this slide and it would be kind of tedious to read them all. The first question is, how long does it take to implement PDQ and how many staff are needed? So MTI's experience is that we need about 3 to 4 weeks to get through phases 1 through 3, using 1 full-time staff, 1 half-time staff, and 1 25% staff. And then after the 3 phases, you really only need 1 staff person who does follow-up at the monthly quality improvement team meetings. The follow-up is really important to make sure the QIT has an action plan, is trained, and is functioning properly. And then I'm going to go to the last question on the slide that says, how How can PDQ be taken to scale given the intensity of the work and time needed? This has really been an issue in several countries, and it really depends on having some kind of minimal sustained funding so you can continue in the communities, and manpower for monitoring and support like they had in Liberia. PDQ is more feasible as the quality improvement component of larger projects and when the local government has prioritized it. And this is very important. In Liberia, we have a lot of support from the Ministry of Health. And I don't know if, Andrew, if you would like to share about some of the ways we're looking at PDQ in a new county now, in Sino County, to look at different ways to approach the process.
Beth, thank you. Like you mentioned, I think it's not an expensive methodology to use, but it is long term. And anytime we're working with the community, like you said, we kind of need some minimal budget that would be longer term in order to really follow up on these quality improvement teams. One thing we found in Sino County, which is in the southeast part of Liberia, it's a very large land area with kind of not very dense populations, and so the health facilities that we're implementing this in are spread apart. But we've been able to divide our staff into two teams that can go and facilitate this process within the communities, and then bring people together at the health facility. And these two teams can add a new health facility through all three phases, within this time frame that's listed above, in 3 to 4 weeks, and that's with the staff that we've listed there: one at 100%, and one at half-time, and one that's kind of doing mostly other activities, but just supporting in some of the areas. So I think it's really feasible to take it to scale, especially if the staff are available and there's commitment by the government.
And I would just add that, in the PDQ implementations that I've done in different countries, I think there was always this idea that it was going to take 2 or 3 months in each community, so it felt very onerous. But I think in Liberia, we've been really able to have staff working closer to the community level, and they're able to get out there more often, and it's really sped up the process, and that's really great. So now I'm going to move on to the next slide here. So the next section is a discussion questions which draw on the experience of the viewers and are meant to enhance discussion either in plenary or in small groups after you have shown the video. So in the learning tool that we developed, there are 11 discussion questions. So the facilitator can pick and choose which questions make the most sense for your audience. So I'm going to go through 6 of those questions quickly with you just to give you a taste of the tool. The first question is, have you implemented the PDQ process before in any sector? So if you have, could you type in that you have? And if you'd like to type in kind of what were your experiences. And, like who were the partners? Like in the health sector, you have the community members who are the vulnerable groups, who are one partner in the partnership, and then you have the clinic staff who are on the other side.
Beth, as people are typing in their comments, I thought maybe I would just address the issue in the poll about how facilitators are trained. Someone made a comment that facilitators are key to this process, and that's absolutely true. Beth, maybe you wanted to touch just a little bit about our hands-on process that we used here at MTI.
To train the facilitators, you mean? That's what I think you're talking about? Yeah, so the facilitator of the process, well, the staff at MTI or the implementing NGO need to think through if they have the right people on the team, and that happens kind of before you even get started in phase one. And then the facilitator of the Bridging the Gap session needs to be someone who's not on one side or the other of the partnership. They need to be a neutral facilitator, and they need to be really skilled at listening and maybe even conflict mediation if there's any kind of conflict during the Bridging the Gap session. So they're trained in the sense that they know the communities, they know how to listen to the communities. I don't know how much more to say about that, but it really can't be anyone that takes any one side. And I see that Gail Sinetro is on the line, so this is really exciting because Gail has a lot of experience with the PDQ process as well. So I don't know if Gail wants to share. Let me see. USAID, the community members and health facility staff were involved. Okay. Building support phase. Partners are on board for the building support phase. Okay, I can't see all of the notes, but I can see some of the notes here. Okay, so pleased to see PDQ video. We have found that having the ministry on board in the building support phase is very important. Yes, so that's actually really critical. I agree with that. I think was Ram Shrestha, or was that Gail that wrote that? Because of course you need to have their support, and what we found in some communities is that there's a little bit of pushback if there already are existing like community health development committees or something like that. They may be wondering, what is this quality improvement team thing? So sometimes there's a sort of a negotiation or a kind of a pilot time to see how one might be integrated in the other. And in Liberia, we're seeing that now that the Ministry of Health is really supportive, we're probably going to end up integrating the quality improvement teams in with those existing structures. Ram Shrestha is asking how many days of training for the facilitator. The facilitator for, you're asking for the facilitator for the Bridging the Gap session, or you're asking for the facilitator at the implementing NGO? In your experience, what motivates a quality improvement team meeting regularly? Okay, Bridging the Gap session. We don't do a formal training of the facilitator, but it's someone that oftentimes it's from our own organization because we're not really known as being from one side or the other. And so it's someone who is really experienced as a facilitator who can manage difficult questions or people who may not agree on either side. And then the question about motivating quality improvement team, I think we can get to that at the end of this. This is a question that our Haiti team had a little bit of issue with, and they were able to, they're still struggling with it. I think that's one of the most difficult things, is thinking about, how do you motivate people to keep on meeting every month? So let's continue on. To the next slide. So the second question here talks about social barriers. And one of the things that we put in the, we were announcing this webinar, is to think about what are some of the social barriers that you saw when you were viewing the video. PDQ attempts to address the issues and barriers that the community has tried to overcome, but has not had success. And most of these are social barriers, things that are kind of outside of the health system that keep people from using services. They could be structural, environmental, cultural, etc. And addressing these barriers as social barriers is pretty unique, I would say, and focuses on the viewpoint of the community members and the providers' daily struggles to achieve good health care at the community level. So we see here two questions. What were some of the barriers mentioned in the video, and what other barriers do you see in the communities that you work in? So Andrew is answering Ram's question about number of days of training. The field staff, our team, yes, our team went through a pretty extensive training before we started implementing PDQ. It was not 8 or 9 days. Okay, I'm going to see if anyone has any other things to share about social barriers that you saw. Okay, I'm looking at this comment about integrating the PDQ process into existing facility quality improvement teams in certain districts. Yes. Yes, and I think that's really critical because if there's any kind of threat perceived by the existing community leaders, then you're not going to have much success with PDQ. So I'm going to move on, continue on to the other questions to make sure we can get through these slides. The next question has to do with Phase 2, exploring quality. As you recall, Phase 2 is when the implementing NGO conducts focus group discussions with the community members and providers. In the warm-up to the focus group discussion questions, the facilitator tells the story about buying cassava in the market. This is often a long and drawn-out story that people really like a lot, and it helps them to understand this idea of quality. So the question here is about, why do you think that understanding the meaning of quality is important?
Yeah, Beth, as people are typing in, I'll just jump in here too. I really like the story that the video used as far as cassava, but I do know that in other countries they've used, how do you choose which tomatoes to buy, or how do you choose which, whatever to buy. And so I know there's kind of different answers of why people, how they understand quality. I guess for me, what I love about this methodology is it gives a voice to people that are deciding on quality other than the normal authorities. For in a health context, normally it's the Ministry of Health or some accrediting authority that decides what's quality service. But in this methodology, we're really trying to understand that the community and the users, or even those that are not using the service, can also define that quality, and they can give their meaning of what it means to have a quality service.
Yes, I agree completely. And it's, I just find that that's often the missing link. And I know that there are other methodologies out there that look at, this idea of quality and quality improvement, but linking it with people's rights and realizing that they actually have a right to choose, the cassava in the market, but also the whole experience of going to the market. How does that relate to their experience of going to the health center? Not just the actual getting the service, by the provider, but the whole quality of everything about that experience of going to the health center and getting a service that they have the right to get. So I see Janine saying it confirms community ownership and partnership. Yes. Okay, so we've got some good discussion going on about quality here. And, maybe it is, when a lot of health folks look at the word quality, they're often thinking about the technical, the provider's technical competence, but we're looking in a much broader way, and having it be defined by the community members together with the provider, like in the community, is really powerful. So I'm going to go on to the next slide. So as we've stated, PDQ can work in a variety of sectors. Of course, we mostly have examples in the health sector, but regardless, the most important thing is that there are cohesive communities within a given catchment area that pertain to a provider or a group of providers that are responsible for providing a service. So when we say providers, we're talking about clinic staff. So that means some are clinical, some are non-clinical. And PDQ works best when there is strong motivation for change. And this gets to some of the comments that we've already had about motivation. It is more difficult when there is NGO saturation, which could create an expectation of per diems or other kinds of incentives. And this is something that we need to really pay attention to, because in some communities they're used to getting paid for coming to meetings. So if that's happening a lot in a community, how are you going to get people to volunteer to come to meetings for something that's going to help their community? So what we'd like to ask you is, what are some country or program contexts where you think PDQ may work well? There was some discussion by some colleagues of mine about urban versus rural, and that's a very interesting idea of thinking about trying to do PDQ in an urban setting, because you may not have a cohesive community, or you might need to define your community in different ways. So Gail says we are looking at applying PDQ to the basic education sector. So that's great. In education, you could clearly define, two sides, right? Like the administrative side, and then the recipients, meaning the students and perhaps the teachers. Anyone else? Any other sectors? FSN
I'm curious
Network
if any,
looks at food security.
yeah, I was just going to say, has
Sorry, go
anyone
ahead.
heard of this being used in the food security sector or agriculture generally? Has any experience?
Yeah, so Steve is saying agriculture, especially related to cooperatives. Yes, so I would like to hear more about that. I think there's so much possibility for PDQ being adapted for food security that it's just a wide open possibility there. So I would like to know who do you see as those partners in agriculture? Would it be like farmer field schools and uh, the community members? Within cooperatives, it could be any level value chain. Okay, great. I think I heard of one experience. Georgetown Institute for Reproductive Health was doing PDQ, looking at I think they were working with commercial sex workers, and you have to really adapt, or think differently about the methodology with that kind of audience, because maybe they don't want to be recognized or known. So bringing them together for bridging the gap might not be a good idea. So I think for each way we think about using PDQ, we need to adapt it for our audience. So I'm going to move on to discussions. Question 5. PDQ is a flexible tool that allows for adaptations to the local culture. In Liberia, the exit interviews were conducted by pairs of quality improvement team members. So you had one person who was literate and one person who was non-literate. In Pakistan, when I worked at Save the Children, it was fascinating because we had to work within very strict gender roles. So we used different team building games rather than the one that was in the video, since men and women can't touch each other. And then the quality improvement teams were separate for men and women as well. And in Haiti, MTI works more at the health post level rather at the health center level. So you wouldn't be talking about people saying they want to go and deliver their child, but you could talk about why they don't go to the hospital for services. So, and in Haiti, we spent a lot of time informing community members what they can and cannot go to the health post for, and there was a lot of discussion about why they would go to a traditional healer or not. So it was a different setting there. So our question for you is, what kinds of adaptations do you foresee would be needed to conduct the PDQ process in the communities that you're working in?
Beth, I wanted to mention another adaptation that we've seen here in Liberia is using civil society or community-based organizations to kind of play the part of conducting these exit interviews and trying to be a neutral third party between these two partners.
I like that. Anyone else want to share? So there's a wide variety of adaptations, and I can think of so many. Just when I was at Save the Children, we did a lot of the training using a facilitator's guide that was really PowerPoints discussed in a classroom, and I think one of the adaptations that I felt was needed was to actually include hands-on work, and I feel like that's helped make the PDQ more relevant for the society, for the culture, because as I did the training and would go into the communities and do the practice, we would adapt it as we went. So I'm going on to the next slide here. Question 6. Save the Children developed the PDQ monitoring and evaluation toolkit in 2010. Many of the tools come from Save the Children's experience in Pakistan, where we scaled up PDQ nationwide. Can you remember which tools were mentioned in the video to measure quality improvement? There were several different tools that we used, and we had a PDQ technical advisory work group where we discussed how PDQ was most effective, and out of that came this toolkit. So Gail's saying, also looking at integrating the scorecarding process as a service delivery monitoring function that could be sustained over time. Okay. So the scorecarding process, that's looking at like the community scorecard model. So it's a way for the QIT to continue even after the NGO support finishes. I like that idea. So that's one of the things when we start talking about monitoring and evaluation and sustainability, you put a lot of effort up front and you really want it to stick. You want communities to take charge and continue on their own. So that's a great way to do this. So we also wanted to know kind of what were some of the challenges that you face when you're measuring quality. I know that we've got Ram, Shrestha, and Gail on the line who have a lot of experience doing quality improvement. So I know we face a lot of barriers just getting our brains around, if quality is really defined by the communities, and how do you measure it? Do you measure it differently for each community? And what we ended up doing for the M&E toolkit was building a lot on Gail's work, actually looking at how do you measure community capacity? What are some of the indicators? How can we take some of those indicators and convert them into an exit interview, for example? Questions that will say, to what degree do you feel that you're part of the quality improvement team? And asking those vulnerable groups, do you still feel like you're included? So things like that, I think, really get at, do people still feel like they're being listened to? And the exit interview is important to continually, every month, get a gauge on, do people feel like that they're getting the services that they want and need. So the skills in the toolkit require training and staff to gather and analyze information, but they help us to see if we're having an impact. In these tools, we measure things like the level of QIT participation, generation of internal and external resources, and the comfort level of individual QIT members as part of the group. So this information, along with the health center reported data, such as the number of facility-assisted deliveries, help us to have a full picture of whether quality, as defined by the community, is improving. And one of the things that's difficult is measuring what the value added of PDQ is in one community compared to another. For that, we could compare PDQ and non-PDQ communities, but that would still have to factor out other differences between those communities. MTI is just getting into data generation from PDQ, and so we haven't really gotten super deep into the evaluation so far. We are hoping that the video will help generate more interest in using PDQ. So next steps for MTI. So here you see MTI's next steps for rolling out PDQ, the PDQ video and the learning tool. In Haiti, we're having a launching event coming up this week. We have over 20 organizations that are going to be attending in a half-day event in Port-au-Prince to share the video and have a discussion. Andrew, would you like to share what's going to be happening in Liberia?
Yeah, sure. On January 31st, we're going to have a similar event where we're inviting partners and interested donors that have looked at this methodology in Liberia in the past. And actually, the Ministry of Health will be speaking at the event. It's on the 31st, which is a Tuesday. Anyone listening in Liberia or that would like to fly over for the event, they're welcome. But it'll be just a half day as well, where we'll be sharing resources and talking about a way forward, specifically in Liberia, looking at the new community health policy that is being rolled out nationwide, and the Ministry of Health's interest in using this methodology as a quality improvement tool for that new rollout of that program.
Great. And so in addition to these launching events in Haiti and Liberia, where MTI has been using PDQ, we're going to be, putting the video. We actually already have the video and the learning tool on our website, and announcing through other social media and conferences and things like that. So we're really excited about this. It's interesting because, as I mentioned, it's not a new methodology, but we're really trying to focus in on, how do you measure it? How do you take this kind of thing that's been included in other bigger projects and really show the value added that it can have? And, I'm really a believer in PDQ, so I'm going to promote it as much as I can, and I know that Gail is as well. And I hope that, after seeing the video, that you're excited about thinking about how you could implement it as well.
Beth, I wanted to just make a comment about the video and just its accessibility worldwide. It's obviously available on the FSN network, which I think is how most people were able to view it. But in the chat box, I did also provide the YouTube link, in case people were having a problem accessing it on the FSN network site. I know that sometimes bandwidth is an issue, and even here in Liberia, we were unable to really stream it with high definition. So I was able to just take it even off of YouTube, put it through kind of a third-party site and download it in a pretty basic format so that the file was not nearly as large. We put it on a thumb drive, and then we've been able to share it with our teams in the field with very limited internet access. So that's just one idea.
And you have a CD of it as well, right? Is that what we have
We do, but
DVD, I
so many
guess.
times now the laptops are not really even coming with a DVD drive. So we found that a flash disk or a pin drive is a bit more practical.
Yeah, okay. Yeah, it's been a lot of work to try to, get the video launching started, just for some obvious logistical reasons. But it's interesting that there hasn't been a video all these years, and I think there's something about seeing it, visualizing the steps in the field that really make it more approachable and feasible. And I don't know, I've heard a lot of great responses from folks who, just they read the manual, but then when you actually see it, they feel like it all comes together for them. Okay, I'm seeing some great responses here. So, got one more slide here, and we would just like to open up the floor for more questions and comments. And I would also just like to take a minute to thank the TOPS Small Grants Program, which funded this project. The TOPS program is administered by Save the Children and funded by USAID, and we want to just thank them very much for their support in making this project possible. It's been a lot of work, but it's also been a lot of fun, and I'm hoping that we get a lot of people thinking about using PDQ now because of this. And the recording of this is going to be available, so if you have other friends that you would like to have see this, they can get the recording of this webinar on the FSN website.
Beth, I wonder
So
if we have
thanks.
some time to go ahead and discuss a bit more of Ram's comments on quality, or Gail's comment just about really how to measure the outcomes and the impact of PDQ.
Okay, great. I'm looking at the questions here. So Ram says, in your experience, what motivates QI team to meet regularly? So this is an interesting thing. What we have found in communities where there aren't very many or any NGOs at all, except perhaps our NGO, it seems to be easier because there, people welcome opportunities to help coordinate change in the communities. If the stakeholders, as was mentioned, if the stakeholders are on board and really see and are convinced, I mean, maybe showing them the video, if they're kind of seeing that this could be a useful methodology to resolve some differences, which may be some really simple, petty sort of gossip site sorts of things, if they see the value in that, then the community is much more likely to come on board. I think getting people to come to monthly meetings has been an issue, and one way we've really tried to promote that without it being an onerous burden on one person more than the others is to have each month have the meetings in a different location within the catchment area so that no one has to walk any further than anyone else. Having rotational leadership, besides promoting equity, it really kind of gets people thinking that they have a chance to be a leader. And starting with small wins, having, the first item that the quality improvement team starts addressing on their action plan be something that is, pretty simple, that's very motivating. and making it very clear up front that if they want to have food, that the implementing NGO is not going to provide it, that they are going to have to perhaps bring their own. So really instilling that idea that this is their own health center, and they've got to do it for themselves, and that really needs to come from them. Any experience in getting the community to understand quality? I think that the market story, one thing that was interesting, besides doing the market story with the community members, we ended up starting to do it with the providers as well, and surprisingly, they liked it a lot. So, because I assumed that since they've got more education, perhaps if you just say the word quality, they'll get it. And using the sociodramas that were in the video, that's not in the original PDQ manual. When we started doing PDQ for youth, we added the sociodramas after the focus group discussions, and now with the great response we got, I'd like to encourage that with all audiences. I feel like the sociodrama gives you more insight as to people's emotions and feelings and of how they feel treated. Gail saying, we are constantly challenged to see the outcome impact as the result of PDQ. So happy to hear about the data generation for PDQ, as often we need retrospective evaluation or more time to see these results other than the life of a project. Would be nice to get some funding to revisit PDQ efforts in multiple countries over time. I love that. Let's do it, Gail. I really feel like, if we could just capture some of this data across countries. When I was at PDQ, when I was at Save the Children, we made a list of countries where PDQ had been implemented, but it was difficult to get a grasp on who was doing it, and if it had already ended, then we wouldn't have that data, or if the staff person wasn't there. So we do need some coordinated measurement across countries. Janie says it's also motivating to link QITs to other community structures, WASH, NIDs, mass drug distribution, etc. Yeah, I think that's a real important thing to think about, so as to have the efforts be sustainable, to look at what's already there. In Nepal, when we worked at Save the Children with PDQ for Youth, they already had the VDCs, the Village Development Committees. So they organized it so the youth QITs would meet, and then they would come in the last bit of VDC meetings and share their input in that way. Another question is, what data is gathered to measure impact? So to gather impact, we're looking at impact indicators, things like has the number of facility-assisted deliveries increased, over the life of the project. But again, we would have to compare PDQ communities with non-PDQ communities. And I know that in Pakistan we actually did that, and we saw a significant difference. There were more vaccinations taking place in PDQ communities versus non. And in the video, I don't know if you saw the very last clip, there was a the provider talking about the transformation that happened when they overcame the issue of the disagreements between the provider and the community members. Well, so there were so many other reasons, issues between the clinic staff and community members, and vaccination was one of them. People didn't want to get their kids vaccinated from that provider. And so those numbers went up. So it's amazing, the kind of change that can happen when you break those social barriers. And Gail says, dreamed of integrating PDQ thinking into pre-service versus in-service capacity building, so the service providers can continue to promote and support PDQ as part of their basic skills for assuring quality. Oh, I like that. Okay, so let's think about that. I mean, it's thinking about community members and the social barriers that they face when coming to seek services, if I understand you correctly. So that might be starting, not starting from the training that providers get, having them think through the perspective of the user. Jenny
Just
says
to
we can
comment
explore
on
the
Gail's
issues.
comment too.
Yeah.
I do think it's a good idea to think about including it in their in-service or pre-service training. But part of the benefit I think of the PDQ methodology is having a third party that's not really either a provider or someone who's using the service. And so if it was just done in training, then it would be hard for that provider to be really a neutral party.
Mm-hmm. Yeah, I agree. I'm looking at Jenny's comments. We can explore the issues, bridging the gap, and take them to the cycle. Okay, so you're saying that through by walking providers as they're going through their training, walking them through the steps, maybe showing them the video, um, they could have more of an understanding of the viewpoint of community members. So it's almost like you're preempting or you're foreseeing potential issues before they are happening. So I think that's what I understand you to say. We need a neutral party to facilitate. Was more thinking about reading them for the process of including communities in defining and working towards quality. Okay, yeah. Yeah. Yeah, we do need a neutral party to facilitate because, yeah, because that may just continue to keep groups separate if you don't have a neutral and skilled kind of facilitator organization or person, but I think an organization is better than just a person. Andrew says, I'd be interested to hear if anyone has plans to show this video to your staff or to partners. And Gail, are you still based in South Africa or are you in the US now? Preparing service providers to accept the involvement and the right of communities to define quality. Oh, I like that. Okay, that makes so much sense. Rather than, waiting until they're in the community and faced with issues to actually go, and during their training, preparing them for this. So this is wonderful. Thank you so much. Yes, we'll be showing it to our staff for sure. Yes, you're based in Johannesburg. Wonderful. Well, thank you so much to everyone for being on the webinar. This has been really interesting, and I want to go back and see people's comments again and think through. And we'd love to continue this discussion if you've got other ideas or want to think about how you might want to use PDQ. We're not really territorial or anything. I mean, clearly, we want people to use methodology, and um, it's been very positive in my experience. So very excited to see the video. Yes, thank you, Gail, for that comment. And it was a lot of fun to put together. And I feel like, I'm just kind of channeling all that I learned at Save the Children through the PDQ process. And Gail, you were a big part of that. Very interesting webinar. Gail, so I hope that you also can share this more at Save the Children. I don't know who else has seen it over there, but I hope that it gets shared. Yeah, and Ram, I know that you have some other quality improvement methodologies, and it would be interesting to do some comparisons. Oh, Gail, thank you very much for sharing it. Save. That's about the cost of NGO staff and preparation. We didn't talk specifically about costs, I think, because funding really does vary and availability of staff really varies depending if you have a larger project. But there was a slide on number of staff that would be needed per community. So, so I think that that really the answer is kind of it depends. How about how the sustainability? It's similar, but using community systems, but the same PDQ concept that I learned in Nepal. Yes. I think that, I don't know, Andrew, do you have anything to say on the NGO staffing question? Okay, I think we have reached the end of our time here, so I want to thank again everyone for your participation in the great discussion, and and I know for some of you, you need to move off to other meetings. So thank you very much also for the nice comments on the video that you found it easy to follow and to help that it really helped understand and visualize the steps. Okay, great. Thanks everyone. And thank you, Andrew, for your co-facilitation.